Hello and welcome to Perspectives on PH. I'm Thomas Baldrick. PAH.TV brings you up-to-date coverage on some of the latest abstracts presented at the 2013 American Thoracic Society International Conference. For all the related abstracts presented in PH, please visit the ATS website. We had the pleasure of speaking with Dr. Vallerie McLaughlin from the University of Michigan. During ATS, Dr. McLaughlin identified some key abstracts that she would like to highlight. These include new data presented on Macitentan, Riociguat, Treprostinil, Bosentan, and Sildenafil. Welcome, Dr. McLaughlin.
Thanks, Tom. It's a pleasure to be here with you today to discuss some of the very important data that was reviewed at the ATS meeting. The first abstract was Macitentan and its impact on hospitalizations during the SERAPHIN trial. As you may know, the SERAPHIN trial is a very large and was the first ever event-driven trial in pulmonary arterial hypertension. 742 patients were randomized to Macitentan 3 milligrams, 10 milligrams, or placebo. One of the outcomes that was measured in this trial was time to either death due to PAH or hospitalization due to PAH. And this abstract reviewed the data with that. Overall, there was a 33% reduction with the 3 milligram and 50% reduction with the 10 milligram in the time to death or hospitalization due to PAH. And when you look just at hospitalization due to PAH, it was a 39% reduction with 3 milligrams and a 50% reduction with 10 milligrams.
Doctor, what are the key takeaway points?
Well, Tom, as you know, hospitalizations usually signify progression of pulmonary hypertension or need for additional treatment for heart failure or more intensive therapy. And clearly this is a signal of the progression of the disease. And I think one of the things that we learned from this first ever long-term event-driven trial is that we have a therapy that has had a positive impact on measures of progression of disease, and this specific measure looking at hospitalization. Of course, this has an impact on the patient's quality of life also. If they're staying out of the hospital, it's very likely that their overall quality of life is better. And I think the most important thing we've learned is that the longer-term data is very valuable and gives us a reflection of how patients are going to do over a number of years rather than just 12 or 16 weeks as we've studied in previous placebo-controlled trials. So, Tom, the next abstract I would like to discuss reviews the hemodynamic assessment of patients who were in the CHEST-1 study. As you may know, the CHEST-1 study was a double-blind, placebo-controlled, randomized study of patients with chronic thromboembolic disease that was either inoperable or persistent after pulmonary endarterectomy. The results of this 261 patient trial were previously presented at the CHEST meeting this year, and it demonstrated an improvement in the primary endpoint of 6-minute hall walk. This particular abstract looks at one of the secondary endpoints, and those were the hemodynamics. Overall, in this trial, after 16 weeks, there was a slight reduction in right atrial pressure, a significant reduction in mean pulmonary artery pressure of about 5 millimeters of mercury, and an increase in cardiac index of about 0.5 liters per minute per meter square. And that was significant. These changes in hemodynamics are actually quite similar to the changes in hemodynamics that have been reported in other shorter-term clinical trials in pulmonary arterial hypertension. So this is a very positive secondary reinforcing endpoint in that clinical trial. And Riociguat, which is a novel agent, is really the first agent that has been demonstrated to be efficacious in patients with chronic thromboembolic disease, which is an important and underserved diagnosis. The second Riociguat abstract I'd like to discuss, Tom, is from the Patent 1 trial. Patent 1 was also previously presented at the CHEST meeting this past year and is a study of Riociguat in patients with Group 1 pulmonary arterial hypertension. And that study demonstrated an improvement in the primary endpoint of 6-minute hall walk. The particular analysis that was presented at ATS looked at the different populations that were entered into the patent study to determine if the effect on 6-minute hall walk was similar in patients who were pretreated with other PAH agents, specifically endothelin receptor antagonists or non-intravenous prostanoids, versus those patients who were treatment naive. And what we learned from this analysis was that there was an improvement in that primary endpoint of 6-minute hall walk in both the treatment naive and the pretreated patients, suggesting that across the board, Riociguat was effective in improving 6-minute hall walk in patients with Group 1 pulmonary arterial hypertension. Again, this is an important trial because we are very excited to have an agent from a new class available to treat patients with pulmonary arterial hypertension. And of course, it is very likely to be used with some of the other agents that we have. And it's very nice to see that it has incremental efficacy on top of these other agents when compared to patients who are treatment naive.
Doctor, what is your initial impression of the Riociguat studies?
Well, Tom, I'm very excited about Riociguat. It's nice to have a drug that has an entirely new mechanism of action, a soluble guanate cyclase stimulator, so it's nitric oxide independent. The data in both Group 1 PAH and in chronic thromboembolic disease looks very positive so far, with an improvement in the primary endpoints and many of the secondary endpoints too. I'm particularly excited to have a drug that has demonstrated efficacy in patients with chronic thromboembolic disease, because right now none of the other therapies really are indicated for that. And I'm also excited that in combination with other agents such as ERAs, the Riociguat has demonstrable improvements and even almost the same as what we saw in the naive patients. I do think there's more questions that need to be answered about Riociguat, and of course we will gain more experience with it as time goes by. There's really been very limited experience looking at Riociguat with the PDE5 inhibitors, and of course they work on the same pathway. So there needs to be some caution there, and perhaps we will get more definitive data on that in the future, but right now there needs to be some caution. Riociguat is currently undergoing regulatory review, and we should know later this year regarding the FDA approval of it and its availability to a broader group of patients in the U.S. Tom, the next study I would like to discuss is referred to as the CTREPH study. It looks at subcutaneous treprostinil for the treatment of severe non-operable chronic thromboembolic disease. Of course, we just discussed chronic thromboembolic disease with respect to Riociguat, but there has been some experience trying to use other agents since we don't currently have anything approved for chronic thromboembolic disease. This study gives the interim analysis of 54 of the 92 patients who were enrolled and randomized to either a low dose of subcutaneous treprostinil, a target dose of 3 nanograms per kilogram per minute, and the intention here is really for that to serve as a placebo, or a high dose with a target dose of 30 nanograms per kilogram per minute at the end of 12 weeks. So when one looks at the impact on the primary endpoint of 6-minute hall walk in patients who were randomized to the low dose, you see essentially no change, less than a 5-meter improvement in the 6-minute hall walk. Whereas the patients who were randomized to the higher dose, the 30 nanogram dose, had just over a 40-meter improvement in their 6-minute hall walk. And this was not quite statistically significant. Of course, it's just an interim analysis without everyone enrolled. There were also improvements in hemodynamics, and in fact, there was a statistically significant reduction in the pulmonary vascular resistance.
Dr. McLaughlin, have you used treprostinil in CTEPH? And what is your impression of the findings presented in the CTREPH study?
So, Tom, of course, we see many CTEPH patients who either aren't surgical candidates because of their anatomy, the distal location, or have persistent pulmonary hypertension after pulmonary endarterectomy. And since there's not a currently approved therapy, we have used some of the therapies, including treprostinil and other prostanoids in patients who had still severe pulmonary hypertension and limitations to that, really without any other treatment options. And I would say that our results have generally been positive. I think that many patients improve. I'm not convinced that the prostacyclins have quite as much impact in the CTEPH patients as they have in patients with group 1 disease, but the results of the CTREPH study here are indeed consistent with the clinical experience that I've had. So, Tom, the last abstract that I would like to discuss is a single-center study looking at the outcomes and comparing first-line treatment with either Bosentan or Sildenafil in patients with pulmonary arterial hypertension. At this center, 164 patients were randomized over a nearly 6-year period to receive either Bosentan or Sildenafil as the first treatment for Group 1 pulmonary arterial hypertension. And their long-term comparison was analyzed by looking at time to either death or hospitalization for pulmonary arterial hypertension or the initiation of combination therapy. And what they found was basically at 1, 2, and 3 years, there was no significant difference in either event-free survival or overall survival when the initial therapy was Bosentan versus Sildenafil.
Dr. McLaughlin, what are the clinical implications of the study comparing Bosentan and Sildenafil presented by Dr. Mazzanti?
Well, Tom, I think it's a very interesting study. Of course, there are many things that impact the decision of which agent to start in a patient just diagnosed with pulmonary arterial hypertension. One considers the patient characteristics, one considers the therapies and the side effect profile of the therapies, and of course the physician preference impacts this too. And the question of ERAs versus PDE5s as initial therapy hasn't really been answered in a randomized placebo-controlled way. And so this is an attempt to look at that, again, in a rather small single-center population, and they found no overall difference. So I think it's important to understand that we have many options and that, at least in this study, the long-term outcomes were similar. Of course, it's very nice to be able to have access to larger long-term trials, such as the SERAPHIN trial that we discussed earlier, that can systematically answer questions like this in a multi-center placebo-controlled fashion.
Thank you, Dr. McLaughlin, for your insightful analysis. That's Dr. McLaughlin from the University of Michigan, and thanks to all of the experts who contributed to this edition of Perspectives on PH. We look forward to seeing you here at PAH.TV as we cover the latest news in pulmonary hypertension.